In this lecture, we'll discuss cervical lymphadenitis and all its various causes. So, cervical lymphadenitis is common in children. It's an enlargement of lymph nodes in the anterior chain of the neck. Happens usually between kids usually between the age of 1 and 5, and it's usually infectious, but it can be caused by a number of other things. Sometimes it's caused by drainage of active organisms from infected mucous membranes of the mouth and throat. So these bacteria are essentially carried to the lymph node where they then take over and infect and cause a bacterial cervical lymphadenitis. So understanding cervical lymphadenitis is important, but before we go there, we need to think about what else could this be and understand the differential diagnosis. Identifying cervical lymphadenitis as bacterial is usually best done by taking a good history and doing a thorough exam. So let's look at the key things to look for that are other causes of cervical lymphadenopathy. So one example would be cancers. Specifically, lymphoma may present with multiple nodules. They tend to be firm and rubbery. They're matted and immobile, and they are non-tender. The patient may have a history of weight loss or other signs of systemic disease. This is true for most of our cancerous causes of lymphadenopathy in children. They tend to be multiple, firm, rubbery, fixed in position, and non-tender. What about viral disease? Viruses like Epstein-Barr virus and cytomegalovirus can cause profound lymphadenopathy of the anterior cervical chain, but even simple common cold viruses can do it, like RSV, adeno, influenza, or parainfluenza. Usually, viral lymphadenopathy is bilateral. It's not usually unilateral. Usually there are multiple nodes, not just one predominant node. They usually have other symptoms of runny nose, congestion, cough, other symptoms of upper respiratory infection. And for mononucleosis, they usually have a severe pharyngitis with purulent drainage, a spleen or a big liver and spleen, and they may have multiple nodes not only at the neck, but also in the armpits and around the groin. So if they have more of a disseminated disease, that may well be EBV or mono. So what about strep throat? That usually comes with significant lymphadenopathy. Again, this is usually a bilateral presentation. There's usually multiple nodes. This patient will also have palatal petechiae, as you can see here. It may be purulent, much like EBV, but the palatal petechiae is classic. They will have a prominent sore throat, and they will have a paucity of runny nose and congestion. Large tonsils is likely in strep throat. Also, patients with some systemic diseases can absolutely present with lymph nodes in the anterior cervical chain. For example, in Kawasaki disease, that's one of our criteria for the disease. Also, patients with JIA or HIV may have it. And then there's this unusual condition which we see periodically in children called periodic fever, aphthostomatitis, pharyngitis, and cervical adenitis. It's called PFAPA for short. This is a recurrent fever syndrome, but lymph nodes predominate in this disease. Signs of these diseases are usually present other than lymphadenitis. So in Kawasaki, they may have a non-purulent conjunctivitis, swollen hands and feet, a rash. In JAA, they will have arthritis, or in systemic disease, they may have the salmon rash. In PFAPA, they have these other things you see here with periodic fevers, aphthous ulcers of the mouth, a sore throat, and HIV, they may have weight loss and other sequelae from acute HIV. So, we're left now with a patient who we suspect may have bacterial cervical lymphadenitis. There are some common organisms that can cause this, and then some rare organisms that can cause this. Let's look at the common ones first. Staph aureus. Either MRSA or staph can cause a usually purulent bacterial lymphadenitis. If it's MRSA, it may well be needed to be drained right at the outset. Group A strep can also cause a very purulent lymphadenitis, which can result in an abscess. Anaerobes take a little bit longer to form an abscess, but they can, and those are an unusual complication or cause of bacterial cervical lymphadenitis. Often it's a mixed infection. A bunch of bacteria just got in there and started growing. One thing that we see more commonly in kids than you might imagine is Mycobacterium avium complex, or MAC. This is a relative of tuberculosis. It tends to cause a unilateral area that is painful and very red and very warm to the touch. We call it scrofula. Also, TB can do it too, but we don't see that so commonly. Lastly, in the US, especially in children who have recently been scratched by a cat or most likely a kitten, is Bartonella henselae. We call that cat scratch disease. Cat scratch disease can present in an innumerable number of ways, including CNS disease, but its most common presentation is a unilateral large lymph node that looks infected. More rarely, we talked about tuberculosis, also tularemia, which is actually more commonly tick-borne than from skinning rabbits, which is what you read in the textbooks. Likewise, we're seeing outbreaks in the United States, especially on the West Coast, of the bubonic plague, which presents with a whole host of illnesses and a very sick patient, but lymphadenitis is part of that. Okay, we have a patient, we suspect it's one of these bacteria, we're seeing them, we want to know what tests to do. The CBC unfortunately doesn't help very much, but it may identify cancer. And so I do recommend getting a CBC in these patients because it will eliminate the rare cancer that's being missed. Not eliminate it, but reduce its likelihood. A blood culture rarely helps. It might grow something, but most of the time it doesn't. If you suspect Bartonella titers, and every single child with lymphadenitis should be asked, has your child been potentially scratched by a kitten or a cat? You should probably get Bartonella titers. Those won't come back for a while, but it may prevent an unnecessary operation for what is otherwise presumed to be, for example, Mycobacterium avium complex. Also, other testing might be indicated if there's a history of something particularly going on. If you for some reason suspect mono because the sibling had EBV 2 weeks ago, certainly you could do that testing. It is possible to do a PPD or a Manteau test in a patient with MAC. It may become weakly positive, and that may be a clue that this is MAC. If TB is suspected, certainly we should get a PPD, and we may actually also get a quantiferon gold, because that may be the better test, especially in a child who's recently had BCG or some other vaccine that might confuse the picture. EBV or CMV titers may be indicated in some cases where you're not convinced what this could be, and that would change your management. Okay, you've gotten your tests. Now you want to figure out exactly what's going on by imaging. The test of choice to start out with is the ultrasound. Remember, it's a lot less radiation, it's generally pretty harmless, and you can get an early sense of whether this is likely need to be drained or whether you can start off with conservative therapy and just antibiotics. If there's any question, we'll generally proceed to a CT of the neck or an MRI of the neck, recognizing that for MRIs, for younger kids, they typically need to be sedated to hold still, so maybe CT is a better option. Here's a CT of a patient who has diffuse disease of the right side of their head. Okay, so how do we choose antibiotics in these patients? Well, we're going to empirically start off with a broad spectrum antibiotic such as amoxicillin clavulanic acid. That's a great way to start. So oral amoxiclav, because these children typically are not that sick. They may not even have a fever. Then, if that isn't doing the trick, we may admit these patients and either put them on ampicillin sulbactam if they haven't been compliant on their amoxicillin clavulanate, or we may decide to switch to clindamycin for fear that this might be MRSA, which is a reasonably common cause of lymphadenitis in children. If the clindamycin isn't doing the trick, and we typically would give that a few more days because clindamycin is a slow-acting agent as it's bactericidal instead of bacteriostatic. But if clindamycin isn't doing the trick, for MAC, we would recommend surgical excision. It's really the only way that's going to get better. The surgeons tell me that usually these don't come in as a perfect lump, They sometimes just dissolve right there in the emergency room like old cheese. Alternatively, for Bartonella, we may not operate. We may just do supportive therapy. People do tend to use azithromycin, but it's not clear that azithromycin really helps them that much, but time certainly does, and they gradually should improve. So that's my summary of cervical lymphadenitis in children. Thanks for your attention.